Thanks very much for the invitation to present at the Demystifying Long COVID conference. My name is Tanayott Thaweethai. Usually I go by Tony. And I'm a biostatistician based at Massachusetts General Hospital. I'm an instructor in the Biostatistics group here, as well as an instructor in medicine at Harvard Medical School and an instructor in the Department of Biostatistics at the Harvard Chan School of Public Health. And I'm really excited to talk today about methodological challenges in understanding the impact of vaccines and reinfections. A few disclosures. We have some funding support to report, but I also want to disclose that, I'm the lead biostatistician in the data resource core for Recover, which you've heard a lot about at this conference so far, but I have no other disclosures to report. And in fact, all of the work that I'm going to be presenting today is, a summary of the work that's been ongoing in this field and some methodological directions that I think are important to consider when trying to understand the effect of vaccines and reinfections on the risk of developing or the progression of long COVID. So what I want to talk about today is to provide some context and understanding for studies that try to assess the effect of vaccinations and reinfections on long COVID, and how these require really well-designed observational studies. And the point I want to make here specifically is that at this point in the pandemic, it's really observational studies that are going to they're our only way to better understand the effect of these exposures. Randomized controlled trials of vaccines are no longer really feasible, as there's no longer really equipoise due to the known benefit of preventing infection of vaccines. So beyond the fact that almost everybody is vaccinated at this point, it becomes very challenging to randomize someone to vaccination when we know that there is a benefit to vaccination. And so a lot of the research that that's going to, I think, push the field forward in regards to long COVID and vaccination is going to be observational. Of course, reinfections are something that naturally occur. And so that's going to really, the question here is how can we leverage large observational cohorts to answer the questions related to their effect on long COVID? And effect here is also something that I think needs to be really specifically defined. It can mean both prevention and treatment of long COVID. So prevention for people who have yet to develop long COVID, and then treatment for people who have already developed long COVID, and we're interested in understanding whether vaccination can help alleviate these symptoms, or conversely, whether reinfection can make things worse. So there are several ways in which vaccinations can affect long COVID, and I'm going to cover three of them today. And these were actually summarized by this very excellent paper by Rezaghi et al., this study was funded in part by the Recover Consortium, but was for the EHR cohorts and is unrelated to my work with the observational cohorts in Recover. So there's three ways in which vaccinations can affect long COVID. The first way is by preventing infection itself. If you don't get infected, you can't develop long COVID. And so vaccination can prevent infection with SARS-CoV-2 and therefore prevent long COVID from occurring. So that's one way in which vaccinations can affect long COVID. The second way can be by reducing the risk and severity of long COVID in patients with breakthrough infections. So people who become infected, some of them may be protected from long-term effects of PASC by virtue of them having already been vaccinated earlier. And so here, we're looking at the population of people who were infected and seeing if having a history of vaccinations or being up to date perhaps on boosters would affect the risk of developing long COVID. And then finally, there is a lot of interest in understanding whether vaccination can reduce symptoms among those who already have long COVID. So if you start out by looking at a cohort of people who already have been diagnosed one way or another with long COVID, vaccination may affect the trajectory of their symptoms and their condition. And so here we have a longitudinal study where we're looking at whether vaccination is affecting the presence of long COVID in individuals. So there are all these different ways that vaccinations, when we ask the question, what do vaccinations do and what's their effect on long COVID, it can manifest in these different ways. And the way that we design our study is going to have to be addressing particular aims. It can't just be some overall effect on long COVID, as it can have all these different types of effects. And so I want to start off by looking at this study, which looked at the effectiveness of vaccines against long COVID in children specifically. I also have an inclination to look towards studies looking at pediatrics, as I think the pediatric population is one that's often overlooked when studying long COVID, and that's come up many times so far at this conference. And so in this study, where they were looking at vaccines in children, they used an EHR-based cohort looking at vaccinated, comparing them to unvaccinated individuals ages 5 to 11 and 12 to 17. Some call this like school-age children and adolescents. And what they did is they excluded individuals who were infected prior to vaccination. So they wanted to look at whether vaccination prior to infection was going to affect the risk of developing long COVID. And so their outcomes were long COVID actually diagnosed or long COVID associated diagnosis, which they define in the paper as like probable long COVID, which is based on evidence of symptoms and such in the EHR. At some point after cohort entry up to 180 days. And so in this analysis, they essentially just compared vaccinated versus unvaccinated individuals, estimated odds ratios, and then calculated vaccine effectiveness. Conditional logistic regression was used to account for the clustered nature of the data. But the approach that I'm describing here, looking at whether vaccination prior to infection affects long COVID, characterizes an overall effect of vaccines on the risk of long COVID amongst people who were previously uninfected. And so it's really getting at those first two types of effects of vaccination on a population. And so, overall, they found that vaccination did reduce the risk of developing long COVID. But one thing that they did in order to delineate between the indirect and direct effect of vaccination on long COVID was to perform mediation analysis. So this was really getting at whether there is a protective effect of vaccination on infection, which was the first type of effect that I described earlier, and then whether there's a protective effect of vaccination amongst infected individuals. So looking at breakthrough infections, did vaccinations make a difference? And so here, they did a mediation analysis to distinguish between the direct and indirect effect. And I think the results are really interesting and worth discussing. So, this indirect effect, so do vaccines prevent infection? There is a clear reduced odds of being infected following vaccination, indicated by these odds ratios that are less than 1. However, there was an interesting increase in the odds of developing long COVID amongst breakthrough infections, which is a little bit counterintuitive, I think, towards what people might have expected, that this is essentially saying that vaccines did not have a protective effect against developing long COVID amongst those who were infected. And this, and in the age 5 to 11 group in the Omicron era, it seemed that there was even an increased risk. So, one thing that I think is important to interrogate here is why this may have occurred and how this helps us understand, or what could have been done differently to better understand the relationship between vaccination and long COVID. And so I think there are some methodological limitations to consider. And the really important thing here is that if we're trying to characterize the effect of vaccination on long COVID that's mediated through infection, we really need to have good capture of infection history. We need to know all the infections that occurred in these populations to know if vaccinations prevented them. And this can be very hard in EHR-based studies. Think of your own behaviors. It's much less likely these days for people to get tested in a health system and have that test to be recorded in their electronic health record. Most often, people test at home and they isolate, which is better for public health because it means that they're able to isolate rapidly and get rapid answers, but does mean that the quality of data in the electronic health record can suffer as a consequence if people aren't reporting their infections. So this is generally an issue where we're underreporting infections and people are being misclassified as uninfected when really they were. But the challenge here is that if infections are relatively underreported in vaccinated individuals, so vaccinated individuals are reporting fewer infections, we could actually be overstating the indirect effect of preventing long COVID. It may look like vaccination is preventing more infections than it really is. And that's how we could end up with these really low odds ratios for the relationship between vaccination and infection, and then perhaps mischaracterizing that indirect relationship between vaccination and infection. So it's really important when trying to do these analyses and delineating between effect 1 and effect 2, the preventing infection and preventing PASC, that the infection data is really excellent and high quality. Otherwise, it can be really challenging to distinguish between these two effects. So that was a study in pediatrics. I also wanted to discuss in another study related to the effect of the vaccine or a COVID vaccine versus no vaccination on patients who already do have long COVID. So this would be looking at effect number 3 in the figure in the slide that I showed earlier. And so this paper by Tran et al., which was published in BMJ Medicine last year, was a UK-based online cohort called COMPARE. And this was a cohort where individuals completed symptom surveys every 60 days, and then they also reported their vaccination status every 45 days. And in these symptom surveys, they restricted, that allowed them to identify a cohort of people who had long COVID, defined by the bullet that I provided here. And then they used target trial emulation to evaluate the effect of vaccination on the resolution of symptoms. So they were looking at complete remission of symptoms 120 days later, so a binary outcome. And they were trying to understand whether being vaccinated affected the probability of still having symptoms 128 days later. So this target trial emulation is something that you may have heard of in other contexts, and it's been, over the last several years, really gained a lot of traction in epidemiology, in biostatistics, as a way of trying to very robustly perform observational analyses when it's impossible to do a randomized control trial. And so the first step of a target trial emulation is to write out exactly what trial you are trying to emulate. So in a perfect world, if you were actually able to randomize people to treatment or placebo or what have you, you would write out exactly what you would want to do in that ideal world. So why would you design this trial? And then you map your emulation, which is what you're actually going to do in your observational data, to mirror what's happening in the target trial. And so this is a really helpful framework for performing observational analyses, because it forces you to very carefully define your cohort, your outcomes, how people are going to be followed if this is a longitudinal outcome, and then really identify what the pitfalls are of your design so that you can identify methodological tools and strategies to address the sources of bias that may arise where your emulation differs from the target trial. So the eligibility criteria and treatment strategies are roughly the same, which is typical. And so the real difference is that treatment assignment ideally would be done by random allocation to vaccination, no vaccination. Of course, that's not feasible given the lack of equipoise and the fact that most people are vaccinated at this point. So in this analysis, we would classify individuals according to the strategy that their data were compatible with at baseline. And then emulate randomization by adjusting for confounders. So we can approximate randomization by adjusting for things that confound the relationship between treatment assignment and the outcome. And so we're going to be looking at long COVID status 128 days later over this follow-up period. And so essentially, because we are looking at what people actually did, this allows us to estimate a per protocol effect, which can be very helpful in elucidating the effect of various interventions. So this is a visual description of the analysis that they did, where they looked at the effect of vaccination. So essentially, they started by identifying a cohort of people with long COVID, and then they looked at, they had surveys every 60 days. So they looked at periods of 120 days. And follow-up began at the last observation time before vaccination. So this individual was vaccinated in February. And so their baseline was their last observation, which is V0, before then. And then we're looking at long COVID outcomes 120 days later after baseline. So these two participants would be classified as vaccinated. And this participant here, their baseline would be this time point here, not necessarily their first survey. And then their outcome would be measured 120 days later. So these would all be considered vaccinated in this analysis. But what's really helpful about the target trial emulation is that this individual would be considered unvaccinated for this period of time because they had 3 consecutive visits where, they have this baseline measure and then 120 days later, they have their outcome measured. So they were unvaccinated for this period, but they could also serve as their own control. And so this individual would be able to contribute data where they were, well, actually not this participant, but this participant can serve, even though they were eventually vaccinated, they can serve as a control. And then this participant who was vaccinated before their third time would be censored. And so individuals who were unvaccinated still contribute follow-up time to the study, even if they switch treatment arms, which is referred to as censoring in this framework. So we're able to use longitudinal data collected on participants where they have vaccinated and unvaccinated time, and then combine the data together in order to do this analysis, where they're following like the different treatment arm that we've described in the emulated trial. There are various statistical techniques that can be used to ensure that the results are not subject to bias due to confounding. So propensity score matching can be used to match vaccinated to unvaccinated individuals. And then we also have artificial censoring that's imposed when unvaccinated individuals are vaccinated. And then there's inverse probability of censoring weighting to account for differences in or reasons for censoring in these populations. And as I mentioned, individuals can contribute both vaccinated and unvaccinated time. So the target trial emulation framework allows us to, again, account for the fact that people did eventually become vaccinated over time, but allows us to say what happened to people who were vaccinated versus not. And in some places, people can serve as their own controls. So the target trial emulation framework can be very useful for studying something like vaccination, but needs to be done very carefully in order to estimate the quantities that are of interest when looking at vaccination. There's been less published about the use of boosters. And as we enter the 5th year of the pandemic, which is, of course, very hard to believe, a key public health question is the value of boosters, which have become, continue to be readily available, but have much lower adoption rates than vaccination did at the very beginning of the pandemic when they became available. This was a paper that was published just earlier this year that looked at microsimulation modeling to look at the effect of boosters. They observed that those who were age 65 or older or were immunocompromised were more likely to benefit from boosters, but they didn't look at the effects of long COVID. And so I think there's a lot of interest in trying to apply rather than using simulation modeling to try to perform observational studies to look at the effects of vaccination on long COVID, where potentially we could use target trial emulation to look at people who were boosted versus non-boosted in order to estimate these effects. One thing to note, and this is the other half really of the presentation, is the idea, well, not really half, but the other side of the coin of vaccination is reinfection, where there's a really important and complex relationship between these two. The CDC says that if you were recently infected with SARS-CoV-2, you may consider delaying vaccination by 3 months from symptom onset or a positive test. And so a very strong and important determinant of whether someone gets vaccinated or boosted is whether they were recently infected. And so if we're trying to impose balance on vaccinated versus unvaccinated individuals, we have to take into account their infection history. We can't just look at patient characteristics. We want to really understand what's happened to them recently, because that's going to affect the propensity of being vaccinated. And so that's just one of the challenges. But if we think about studying the long-term effects of COVID on individuals, reinfection presents an important methodological challenge that I think is often doesn't get examined enough and is not often considered. So reinfection can be thought of as this invulnerable period following infection. Is someone, we might want to know, is someone at risk of developing long COVID after the acute phase of an infection? And so this is somebody who was infected, and then we start looking at whether they have long COVID starting at, say, 3 months after that point. But let's say this person is infected again around this point. Well, if they're still in the acute phase of an infection, they're not really at risk, quote unquote, of developing long COVID. So this green shaded area is no longer there. And so the challenge here is that if there's an exposure that affects reinfection rate, it may affect the time at risk of developing long COVID. And so if we're comparing two people and someone develops more reinfections, that may mean, and that's the only effect on their risk of long COVID, there is less time at risk of developing long COVID. So we may be less likely to detect that they have long COVID if they are more frequently in the acute phase of an infection. So this is something that has come up in other areas of research. If you're studying pregnancy outcomes, or rather postpartum outcomes, it becomes more difficult to study postpartum outcomes longitudinally if someone is pregnant. And so time to event analyses need to be done very carefully to account for the fact that there is this invulnerable period induced by reinfection. Finally, I want to talk about reinfection as exposures, because I think there's a lot of interest in understanding, does reinfection increase my risk of long COVID? But I think the important thing is to figure out who that question is geared to. So if you're looking at people who already had one infection, maybe you want to know the effect of reinfection on people who never had long COVID. If I've had COVID once, does getting COVID and I didn't develop long COVID, am I still at risk of developing long COVID after my second infection? Or if I had long COVID after my first infection, what's going to happen to me after I get reinfected? And then finally, if I was infected, developed long COVID, but improved and my symptoms went away, am I still at risk of developing long COVID again? And so trying to understand the aggregate effects of reinfection can be very difficult because there are good reasons to think that these three populations might have very different risks of long COVID after their reinfection. And so it's my belief that analyses related to reinfection ought to be quite specifically tailored towards answering specific questions that are specific to particular populations of reinfected individuals. And so here, I think target trial emulation is a very promising area in which people can try to understand reinfection. And of course, if we think of reinfection as the exposure, observational research is our only option. And so target trial emulation allows us to match people where we have similar history of infection up to the point of reinfection, and then we can match people to one another who have similar infection history, then one gets reinfected and one doesn't. And so this can be a way for us to include the longitudinal nature of the data that we may be collecting in observational cohorts to understand the effect of reinfection, that it provides like a really nice framework for thinking about longitudinally collected data, artificial censoring, and so on. So I just want to wrap up by saying that, we're trying to prevent and treat long COVID. That's our entire charge here as researchers, and that we ought to think about these questions specifically about populations of interest and ensuring that particularly vulnerable populations are not ignored. We can't just focus on people at risk of developing long COVID. We have to also think about people who are experiencing long COVID now and understand whether vaccination and reinfection affect their trajectories rather than just worrying about people from getting long COVID in the first place. We have to be focused on these specific populations as well. I hope the other takeaway you take from this is that vaccination and reinfection are very deeply interrelated, and long COVID status, onset, and recovery all need to be well defined. That's how we can have outcomes to analyze in these types of analyses. But beyond that, we should also have robust reporting of infections, even and especially asymptomatic infections, in order to understand the effect of these exposures. So I just wanted to thank everyone for their time and for listening to this presentation. And I'm hopeful that these more modern techniques for epidemiology and biostats can help us untangle the mysteries related to vaccination reinfection when understanding long-term outcomes related to COVID. Thank you very much for your time.